Okay, this is the quick and dirty about massive transfusion protocol, which is the trauma protocol number 8.0. Definition of MTP is replacement of blood components equaling 1 blood volume in the first 24 hours, which for adults would be about 5 units of blood. For pediatrics, it's 70 milliliters per kilogram. You want to initiate MTP or massive transfusion protocol with 2 or more positive findings, either penetrating injury, a positive FAST, an age-adjusted shock index for tachycardia and hypotension, which in the ED we don't really do, but I'll explain it on the next slide, an elevated serum lactate of greater than 3.5, or a base deficit of exceeding negative 8.8. This is a shock index, which is a predictor of morbidity and mortality. What you would do is put the age in, you put their maximum heart rate and their minimum systolic blood pressure, and this predicts how well the patient is going to do. So for this patient, he is 6, his maximum heart rate is 136, minimum systolic blood pressure was 85, he's 1.6, normal is 1.2, so he has an elevated risk of morbidity mortality. The goal for massive transfusion protocol is to replace blood loss and trauma, to treat hematologic and oncologic conditions, and we want to maintain a hemoglobin of 7 grams per deciliter and a hematocrit of about 25%. What comes next? So the physician is the one that will order the MTP, but I would encourage nurses, as they're seeing that things happening in the room, to encourage the physician to order the MTP, because we want it ordered early so that things can be in process in the blood bank. For the PICU, it's going to be an APEX order. In the ED, it's a verbal order on the critical care flow sheet in trauma. The nurse is going to notify the blood bank that it's been activated, and they will ask for the patient's vital information, including their age, their weight, their MRN and CSN. You're going to send off some labs, a CBC, coags, type and cross match, and of course the tag. You're going to collect an ISTAT or EPOC, send a courier to pick up all the blood products. In the ED, we have a blood refrigerator in the med room that has your first packet, which is 2 packed cells and 1 unit of fresh frozen or never frozen plasma. In full traumas, the blood bank will come down with 2 units of packed cells and 1 unit of never frozen plasma as well. So these are the packages, and it's based on weight. So for a child that's less than 15 kilograms, first packet, they're going to send 1 unit of packed cells, 1 unit of plasma, and 1 unit of platelets. This is not to say that this patient's going to get 1 unit of packed cells. It's going to be based on weight. For packed cells, it's generally 10 milliliters per kilogram. So for a 15 kilogram patient, that would be about 150 milliliters of packed cells. So that's, normally a unit of packed cells is about 250-ish, 300. So we'd have some blood left over. So once we start on the first packet, the blood bank is preparing the second one. If you use the second one, they're preparing the third, which is very important, especially now that there's a shortage of blood, that you let the blood bank know when the MTP is no longer required for your patient. So what's in the cooler? Like I said, it's 2 units of O-negative packed cells, 1 unit of never frozen plasma. And if platelets are needed, they need to come from the blood bank. The blood is used, it must be used or returned to the ED within 4 hours of taking it from the blood bank. So you have 4 hours. This includes your tubing, your blood tubing, anything that's the blood is going through, it's only good for 4 hours. So what's the order of administration? For the ED, it's provider dependent. Most often it starts with packed cells, but it really depends on what the physician feels is going on. In the PICU, it's also provider dependent and also based on the thromboelastogram, which is a TEG, which is sent in the ED for traumas. There's a separate lecture on TEG, so I'm not going to go through this. This is just the graph for the TEG. Concerning conditions with massive transfusion-associated coagulopathies. So you're giving packed cells, you're diluting your clotting factors, which could cause more bleeding. So you want to give TXA. Hypocalcemia, it binds to citrate, which is a preservative that's in our packed cells, in our blood products. So after multiple units or multiple aliquots of packed cells, we want to remind the physicians that they need some calcium, which is usually in the form of calcium chloride. You want to avoid hypothermia, so you want to give your blood products through a fluid warmer and also have external warming measures. It can also cause hypo or hyperkalemia, so you want to keep an eye on those electrolytes. So in summary, you want to activate MTP early. You want to keep your patient warm. Make sure you don't activate that triad of death. Watch your electrolytes, and don't forget to notify the lab when MTP is no longer needed.